Hello, everyone, and welcome to my channel, Body Mind Healing. My name is Maria Sanchez. I am a holistic health consultant, a family nurse practitioner, a psychiatric mental health nurse practitioner, and a doctor in nursing practice. The case for today is schizophrenia versus schizoaffective disorder. Both schizophrenia and schizoaffective disorder are mental health conditions. Their onset is usually between late teens to early 30s, although there are always exceptions. Schizophrenia is a severe mental health disorder marked by the presence of psychosis and a progressive decline in overall functioning. Its diagnosis is relatively straightforward due to its distinct clinical features. Schizoaffective disorder is characterized by a combination of schizophrenia symptoms and mood disorder symptoms such as depression or mania. It often follows a cyclical pattern with distinct episodes of illness separated by periods of mood stability. This disorder is generally associated with a better functional outcome than schizophrenia. An accurate diagnosis requires a careful observation and symptom tracking over an extended period. Let's look at these two disorders separately. Schizophrenia, as mentioned above, is a chronic severe mental illness. To be diagnosed, the symptoms need to happen for at least 6 months with 1 month of active symptoms, meaning the psychotic episodes. There is no mood involvement or is minimal. Schizophrenia is characterized by psychotic symptoms such as hallucinations and delusions, disorganized thinking and behavior, negative symptoms such as flat affect, social withdrawal, and lack of motivation, and cognitive deficits such as poor executive function and memory issues. Hallucinations refer to seeing or hearing voices and things that are not real. This can occur with any of the senses: auditory, visual, olfactory, gustatory, and tactile, but auditory hallucinations are the most common. Delusions refer to strong, false beliefs that are not based in reality and are not shared by others. For example, belief that they are being spied on or controlled. Disorganized thinking and speech refers to the difficulty organizing thoughts, leading to rambling or incoherent speech, also known as word salad. Extremely disorganized or abnormal motor behavior. This can range from childlike silliness or agitation, or even a complete lack of movement or talking, known as catatonia. Negative symptoms refer to a reduction or absence of normal functions, such as reduced emotional expression or flat affect, lack of motivation, social withdrawal, and difficulty feeling pleasure, known as anhedonia. Schizoaffective disorder, as mentioned above, is a psychiatric disorder that combines psychotic symptoms with prominent mood episodes. To be diagnosed, the symptoms need to happen for at least 6 months. The psychotic episodes must occur independently of the mood episodes for at least 2 weeks, and the mood involvement is essential and persistent. Regarding psychotic symptoms are those experienced in schizophrenia, including hallucinations, delusions, and disorganized thinking and/or speech. Regarding mood symptoms, again, there are 2 types, the bipolar type and the depressive type. The bipolar type includes manic episodes or mixed episodes that involves depression and mania or hypomania. Mania includes elevated energy, racing thoughts, reduced need for sleep, and risky behaviors, and often major depressive episodes. The depressive type includes only major depressive episodes such as persistent sadness, low energy, hopelessness, and loss of interest. Let's look at the core symptoms for each one of these disorders. Psychosis in schizophrenia is always present. Hallucinations, delusions, disorganized speech and/or behavior. In schizoaffective, psychosis is present. It has the same symptoms as schizophrenia. Mood symptoms in schizophrenia are not predominant or persistent. In schizoaffective are prominent. depressive or bipolar episodes are essential for the diagnosis. Cognitive impairment in schizophrenia is common, issues with attention, memory, and executive function. In schizoaffective, cognitive impairment can occur but are often less severe. Negative symptoms in schizophrenia are common, including social withdrawal, flat affect, anhedonia, avolition, etc. In schizoaffective, negative symptoms are less prominent than in schizophrenia. Let's look at the treatment approaches for these two disorders. For schizophrenia and schizoaffective, includes medication, therapy, and support services. For schizophrenia, the medication include antipsychotics such as risperidone, olanzapine, aripiprazole, clozapine, quetiapine, lurasidone, etc. Therapies include cognitive behavioral therapy for psychosis, social skills training, and family psychoeducation. Support services include supported employment, housing, and assertive community treatment. For schizoaffective disorder, medications include antipsychotics such as paliperidone, but almost all the antipsychotics are used since they all work well. Mood stabilizers such as lithium, Depakote, lamotrigine, etc. That is for the bipolar type. And antidepressants such as selective serotonin reuptake inhibitors and all the other antidepressants, that is for the depressive type. Therapies include cognitive behavioral therapy for mood and psychosis and interpersonal therapy. Support services include the same ones as schizophrenia: case management, housing, and employment support. In conclusion, schizophrenia is primarily a psychotic disorder with limited mood involvement. Schizoaffective disorder is a hybrid disorder because it combines symptoms of both schizophrenia and a mood disorder, such as bipolar disorder or depression disorder. Both conditions use antipsychotics, but schizoaffective disorder also requires mood stabilizers or antidepressants depending on the type, bipolar or depressive. Schizoaffective disorder requires more nuanced observation than schizophrenia due to its overlapping symptoms, as mentioned above. May the inner peace we cultivate today expand and guide us always. Until next time.